and welcome to the Deuk Spine Institute and Surgery Center Viera live stream of spine surgery. Our patient comes to us from Texas. Sorry, Kansas. Oh my gosh. I apologize. Kansas, that's correct. And I think a family member may be from Texas. That said, she has really bad leg symptoms from pinched nerves at L4-5. We're going to give you some numbing medicine. She's asleep, but I like to tell people that just in case they're a little light. She is has pinched nerves from two things. One is a giant herniated disc that's on both sides of her spine, pinching the nerve severely. The other is a slippage of the bones at L4-L5. We call that a spondylolisthesis. She has both, spondylolisthesis and herniated disc. Now, you're going to see on this x-ray that there's a grade 2 spondylolisthesis. Now, her other option is going to be a decompression infusion. Numb them? Is that my picture there? I'm going to start a little bit lower. All right. Go ahead. Yeah. Our first patient's doing very well. I'm just curious why we have so many needles.
Because like I said, I thought
Oh, right.
yeah, I'm sorry.
Oh, no, go ahead.
You?
Shot?
There you go, sir.
Uh-huh, thank you. No, no problem. you're still freaking me out. Anyway, I thought the freak out was over. It's fine. Shot. So you could see, show us her slippage there, Jordan. Shot. Yeah, right there. Good. And there's a giant herniation. It's so big and so calcified you can actually see it on the x-ray. Show it? Yeah, right there. All right, shot. I need to get into that herniation, and that's what I'm trying to do. To do that, we use this needle. Shot? And I am trying to get down there right now. What am I feeling? Shot? Shot? Uh-huh. Need to be a little bit more medial. There we go. Shot? Let's keep our fingers crossed for her. Now, she has a lovely daughter. I met her daughter. She's a nurse. And she was so excited that her mom was getting fixed today. All right, let's go on the other side, and then we'll do an AP. Lovely people. Didn't want open surgery. Num. Like I said, she wanted less invasive back surgery. Pull back a smidgen, and let's inject just a little bit. Pull back a little bit, and let's inject. Good, that's enough. I'm going to redirect south. If you have questions, feel free to ask me. This is really not a back pain surgery, like most of our cases are for back pain. This is really about pinched nerves, and we call it radiculopathy, which is nerve damage. Shot? All right. She has losing strength in her legs. She has horribly pinched nerves at L4-5. Shot? And if we don't do something to get the pressure off those nerves, she's going to end up being in a wheelchair very soon. Shot? All right. And we're ready for the AP view. Shot? One more time. And AP view. AP view means we're looking front to back. We've been taking pictures from the side. And in spine surgery, you need to do both. All right. I need to be a further medial on the right needle. So the left needle is perfect. You can see the scoliosis. Yep, just take a picture. So I need to be more medial with this other needle. Medial means towards the midline. Shot? There we go. Let's see where that is. Shot? Okay, wait a second now. Let's see. Shot? And shot. I feel what I think is the facet. Let's go back to an AP. As I guide these needles, I need to guide them towards the head or feet more, or towards the back or front more. Oh yeah, that's a little bit better. Yeah, actually that's probably going to be not too bad actually.
You want more?
Again, the left needle's perfect. The right needle, I'm just going to place the left needle so we have that done. That's perfect. Left is perfect. The right side, we need to work on a little bit more. Shot. I think the right side is not too far off. Shot. How is she doing? Good. AP. On the right side.
Okay, good. We're going to ask you some questions. Don't move your right hand, please. I need your hand still.
Any leg symptoms right now?
Any symptoms in your legs right now?
All right.
Are your legs hurting you right now? No?
All right, good. I don't know if she's had much back pain over the years. Shot? You're doing great. We're almost done. We're going to put you to sleep in just a minute. Almost done. Shot? Almost done. I just need to correct this just a little bit right here. Yeah. I have to do the wiggle and a little bit of jiggle. Some of you would say squiggle, but it's basically, by the way, for those of you who don't know, this needle is very, very skinny, but the space that I have to get it through is sometimes even smaller. So even though the needle looks small to you, sometimes my aperture or the space I have, yeah, like that right there, perfect. That space is even smaller. I'm going to do it on the other side.
On the other side, perfect.
Yeah, because this side's easy. I think I'm in. I want to make 100% sure. Let's go ahead and connect the other side. All right. Does she have back pain, by the way?
Yes, 5 years.
5 years. So her biggest issue is the pinched nerves. I also want to point out she has spondylolisthesis. Everyone asks me about that. I have to write fast. Spondylolisthesis, L4-5, grade 2, okay? Everyone says, oh, Dr. Deuk, if the bones are slipping, can you still do the surgery? Absolutely. It still works. Shot. Perfect. And shot. That's nice. AP. Let's make sure this is in the disc and not somewhere else. Shot. Quick shot. Pull towards you. Shot. Oh, perfect. Look at that discogram. It's beautiful. All right, we're ready for her to go nighty-night, and we're going to get this surgery done. You can see the dye leaking out on both sides. Oh, look, see the dye came through on this side. You guys see this, Henry? So we injected that side. It went through the disc and came out here. Huh, there it is.
Yes, we do.
Pretty cool stuff. She's not an alien. She doesn't have blue blood. I think she's got, well, she may have blue blood, but I think she has red blood. Take your time. Take your time, Dr. Berndez. We're not in any rush. Shot. All right, we'll take some questions, and I'll do my best to give you answers. But this lady has degenerative disc disease, spondylosis, stenosis, annular tear, herniation, slip disc, radiculopathy, neurogenic claudication, progressive neurological deficit, weakness, numbness in her legs, neurogenic claudication, I already said that, and severe spinal stenosis. Okay? She doing all right? I'm making an incision. I will go slow, okay? I'll give her lots of numbing medicine just to keep her comfortable. She's asleep, by the way, in case you're wondering. And whenever it comes to doing anesthesia on these type of cases, it's difficult. This is not an easy case to do anesthesia. It's one of the hardest. And actually, many anesthesiologists can't even do these kind of surgeries. They're not any good at it. I had one anesthesiologist I hired, and they literally just kept all the patients awake the whole time. They were not happy, the patients. Let's shot. Do you remember that, Jordan? You were here. Yeah, we never hired that guy again. Huh?
He used a quarter bottle of propofol.
Yeah, he used a quarter bottle of propofol for like all day.
Oh my God.
No, he was deathly afraid of
He's saving a lot of.
patient having a complication, right? So he was afraid to put the patients to sleep. The problem is if you don't put the patient to sleep, then they hurt. And if they hurt too much, they can actually have a heart attack and die, which is bad if you don't control their heart rate. So, yeah, heart rate's everything. Let me know if I can proceed. Shot? All right, so we're going to get ourselves in between the 4 and the 5 to fix this herniation. We're going to do all this surgery without fusing her and without doing a laminectomy. We're doing it from the back side. This technique was developed by Dr. Parvis Camben, Iranian orthopedic surgeon out of Pittsburgh. Wait, let me see. Shot? Yeah, good. And Dr. Camben, brilliant doctor, realized, wait a second, guys, gals, why are we taking all the bones and ligaments out of the back of the spine to get to the disc when we can go from the side and not take anything out? So Dr. Camben started teaching other surgeons how to do it. Well, one of the surgeons he taught was a Chinese orthopedic surgeon who taught me. And then a couple of Korean orthopedic and neurosurgeons. Shot. So, and a German neurosurgeon. And I was taught by them. They were the first generation, I was the second generation. But we've been very successful at getting rid of people's leg symptoms just by doing the surgery and not doing anything else. We don't have to fuse them. I will say that the whole concept of spinal fusion for spondylolisthesis is controversial, meaning that you can't get every doctor to agree on what should be done. Many of them say it should be fused. Many of them say it should not be fused. And it's about a 50-50 thing. Me personally, if I am doing this surgery on a patient, a laminectomy, I'm going to fuse them because the laminectomy will cause instability. All right, let's see what we got. Here's your herniation, by the way. We're going to be taking it out in pieces. I pushed it back into the disc, and now we're taking it out from the tear. Any questions?
At this moment, no current questions.
All right, laser. I'm going to bring the laser in. The laser fiber itself is 1 millimeter wide. 1 millimeter is pretty small. You can see the glass fiber there. We're pretty deep in the disc. I don't think she's going to have that much pain here. These are all pieces of that giant herniation. It's kind of come out in little pieces. Her daughter is a nurse. She works in the hospitals. Actually, she's the one from Texas, I think. And I had a nice conversation with her. She was very appreciative of our staff. And they traveled from Kansas. And she traveled from Texas. Right? I'm pretty sure that's the story. Yeah. Now, being a nurse who takes care of patients, she's seen a lot of bad results of spine surgeries, not from Deuk Spine, but from elsewhere. What a crystal clear vision, huh? I love it. Mm-hmm. Oh, it is National Nurses Week. Yeah, you're right. This week is National Nurses Week, and I said it before, and I'll say it again. We have the best staff. Nurses, staff, we have it all. We have the best. Luis, how many years you been here? 8 years?
Almost
10?
Yeah,
My God. So 10 years. I mean, don't you think we have the best nurses now that we ever had?
Oh, yeah. Yes.
Yeah. Take that. We've had some not so great nurses in the past. few of them come to my mind. But now we have an incredible group. Really, really good. They work well together. They take great care of the patients. All we get is compliments. And they're headed by none other than Mr. Charming himself, Dr. Berndes. Dr. Berndes has got them. You rule with an iron fist, right, Dr. Berndes? Or is it a limp wrist? I can't remember. Iron fist, limp wrist. And then you got Dr. Davis, right? Soon to be medical director, who has been very helpful in the operating rooms. But National Nurses Week. What you guys doing over there? Is that a Swedish penis enlarger?
Yes. I have to use this side, but Bernadette just use that side.
What is that thing?
Flashlight.
A flashlight?
Yeah, so that you can see what you need to see.
Oh my gosh, that's great. All right. Well, for those of you who've been watching, we did do a fusion earlier, a cervical fusion. She's recovering now. It's a she. She had 2 discs fused. Everything went very well. One of the issues with cervical fusion is quality of bone. And if the bone quality is not great, the fusion won't be great. Her bone quality was not great. And that's not something we could do anything about. You know, we had to do the fusion, really had no other option. She had a spinal cord damage from bone spurs, and I had to go and drill them out. All right, any questions about this surgery?
At this moment, no current questions.
Wonderful. This is the herniation, this white stuff. It's very scarred. I get the question a lot, Dr. Deuk, if you get an MRI after surgery, is it going to look any different? The answer is usually not, and the reason is simple. We're only operating in a very small area, and you're not going to see dramatic changes. We're using 7mm tube with an internal diameter of about 5.5 millimeters. So 5 millimeters is pretty much the resolution of modern MRIs. You can get more resolution if you really want as an MRI tech, but most of the MRIs are shot with about 3 to 5 millimeters of resolution. So that means they take a picture that is every 5 millimeters wide. So it's a 5 millimeter. Imagine going to the Publix and asking for, you know, a piece of ham that's sliced at 5 millimeters, right? What that means is that it's a 5 millimeter thick slice of ham. It's not like you're seeing every single picture. You're not getting thin slices. You're getting fat slices. And the reason we do that is, number one, we don't need thin slice data on every single patient. It doesn't help us with the treatment of the patient. But more importantly, it would take forever. It would add a massive amount of time to the MRI scan. And patients would be in the MRI scanner for 2 hours if we got 1 millimeter slices on everybody. So the vast majority of MRIs done out there are done with, you know, 5 millimeter, 4 millimeter slicing. And you're not going to see big changes if you're only sampling every 5 millimeters. The goal of the surgery is to get rid of the leg symptoms. And that's what we plan to do. So not make her MRI look normal. I always tell people you can't make the MRI look normal. Once it's abnormal looking, it's never going to be normal again. Our goal is not to make it look normal. Our goal is to get rid of symptoms. So somebody asked me last surgery about a dynamic fusion. And I don't know if they're still here, but if they are, great. I'll tell you a story where dynamic fusion came from. There is no such thing as dynamic fusion, first of all. You're either fused or you're not. dynamic means movement, or change, means change. But when it comes to dynamic fusion, they're referring to a fusion that's not solid, that it moves. And the original fusions, I just can't twist. The original fusions that moved, right? Dr. Where's Davis? Yeah, the original fusions that moved, we called them pseudoarthrosis or failed fusions. They're still called failed fusions because they are a failed fusion. And what we learned, though, was that a lot of patients that had fusions ended up failing to fuse, but their symptoms went away. And the reason they went away is because we either decompressed them well, but preserved some movement with a fibrous union, it's called, or failed fusion, which is really scar tissue instead of bone. So your body should have made bone, but instead it made scar tissue. Okay? And the reason people make scar tissue where they're supposed to make bone is several things. One of them is movement, unwanted movement during the healing. You got it? So if the patient's bones are moving at the surface where they're supposed to be fusing, then they will not fuse. You cannot have fusion when there is movement. So the whole purpose of instrumentation is to stop movement so that the patient will fuse. So if your instrumentation doesn't stop the movement, then you're not going to get a fusion. You're going to get a fibrous union, they call it, or scar tissue. Okay? Luis, what's going on here? Are you doing all right?
Yeah. Well, what's that?
I don't know. Seem to be fidgeting a lot.
Huh?
You seem to be fidgeting a lot. Fidgeting, like grabbing at things.
Oh, just make sure everything is
So there was the observation that patients who had fusion that didn't fuse, instead they formed scar tissue, they still got rid of their pain, even though there was no fusion. So we started to really rethink, wow, is fusion really necessary to get rid of pain? And of course, we now know the answer is no, it's not. But most doctors still believe it is, and they don't know any different, and they keep telling their patients they need fusion when they actually don't. But some of the companies realized the opportunity and they capitalized on it, and they created these dynamic stabilization or dynamic fusion procedures, which again, they're not fusions. Anyway, that's the history. It's good to know the history, how things come about. So the concept of dynamic fusion is a result of a failed fusion, which nobody wanted, but they happen in a lot of patients whose bodies don't fuse. And even though they didn't fuse, the surgeons noticed that they got better and their pain went away. So they started to market this whole concept of dynamic fusion, making implants that allow for dynamic fusion.
You have 5 minutes on the side?
5 minutes on this side, yeah. You okay with that? This is all herniation here. And again, I will not get 100%. It's not possible. I am not able to get 100%. Nobody can. No surgeon in the world can get 100%. And there is no standard amount you have to get when you're doing a decompression. But what you do want is you want to get enough so that the patient's symptoms go away. And that's my goal here. Get rid of her symptoms. So that's why you don't use MRIs. You use the patients to tell you if you're successful. MRIs will never tell you if you're successful. The only thing an MRI will tell you is if you're taking a brain tumor out, did you get all of the brain tumor? And even then, an MRI can't tell you that, because there are cells that are microscopic, not seen on MRI, brain tumor cells, and well, if the brain tumor comes back, you know you were unsuccessful. It doesn't matter what the MRI shows. MRIs are a wonderful tool, I'm not dissing it, but people put way too much trust and confidence in the MRI, and we've sort of lost sight of doing a physical exam. And the physical exam, to me, is very important. That's where the true answers lie when it comes to diagnosing back and neck pain. Physical exam. All right. Almost done. This is all little bits of herniation. And I'm doing a procedure called a debulking. Debulking. It means, just as it says, to get the bulk out. Right? I'm trying to remove what's pinching the nerve.
We have a question.
Sure.
This comes from Lanu on YouTube,
Hi, Lanu.
asking, can back pain lead to neck pain? Like, is there any connection?
No, back pain typically will not lead to neck pain unless your posture is bad. So there is a connection, and it's through posture. What is your posture? So people with bad backs typically like lean forward. They don't stand straight. And when you lean forward, your neck is going to start hurting because you got to use your muscles. You got to tighten them up to pull your neck back, right? So the answer is bad posture leads to neck pain, but back pain can lead to bad posture. All right? Other than that, there's no connection, except that people with bad disc problems in their back also have bad disc problems in their neck. It's common, very common. All right, we're just looking around. I can see some epidural fat at 12 o'clock, some, fibrous tissue. I just want to make sure I get as much of this herniation as I can safely. There should be a nerve root up there in that mess of scar tissue. And that's the problem with listhesis, is it really distorts the anatomy pretty bad. But that said, we're at a nice trajectory to get the pressure off the nerve in the foramen. 1 minute left at this disc. You can see the bone right there for the end plate. I'm at the back of the disc right here at L5. And I've removed as much as I can get to of the herniation. I think she's going to get some good relief. It will take time for her leg strength to come back after we unpinch these nerves. It doesn't happen overnight. A lot of people think the muscles heal and the nerves heal overnight. They don't. They take months and months. All right. I'm pretty happy with that. I don't see any more herniation. There is still some, but I can't get to it. But the part that I could get to it, I got to. And the part I can't get to doesn't really cause problems. Remember, we talked about that earlier. We never get all the herniation. Nobody can. It's impossible. But you want to get the right part of the herniation. So we need about 50% of the foraminal and lateral recess herniation to go away with the laser. We did that. I've never had a failure with this surgery. I've had people who will re-herniate. About 1% will. But we've never had a failure. We've had some patients we couldn't get to the disc. We tried, and there was just some enlarged facet joint. But as far as if we were successful at getting to the disc and treating it, the patient's symptoms always get better. Always get better. All right. We're going to do the right side. And I took a very lateral approach to this. Okay? Because I wanted to get over as medial as possible at the disc. And what I mean by that is if you start your entry point further laterally on the patient, shot, then you can get more medial in the disc. You can clean out more towards the midline. It's all about this trajectory. Again, Band-Aid, 7mm incision, Band-Aid size, and that's what we put. We put a little Band-Aid on the wound when we're done. Numb them. Shot. We're advancing the dilator. Shot. All right. That should really help. Dr. B and the patient. Here we are. I just went past the nerve. I could feel it. Really tight. The nerve is getting pinched pretty bad. I felt like a rope. Hold on now. Let's just make sure everything is good. Shot. Boy, that guide wire, huh? Wait. Pull it back. Back. It's trapped. Shot. I think we can take it back. Yeah. Shot. So what I've done is I've gone through the tear in the wall where the herniation is. I've pushed some of the herniation back in, and I'm going to take that piece of herniation out. Now, the last one, we didn't get a nice big piece. We got a bunch of little pieces. And sometimes that's all you get, little pieces. What do you think? You think we're good? I think we're good. But my philosophy is it doesn't matter if they're big pieces or little pieces. I'll take as much out as I can get. People ask me, how do you know if you've gotten all the herniation? The answer is, I know I didn't get all the herniation. Right? Because we're not here to get all the herniation. We can't. We can get the part of the herniation causing the symptoms. That's what we need to get. And that's the part that the scope can actually see. You know, where this procedure enters the herniation right where, enters the disc right where the herniation is. So we're actually very lucky with this procedure that it takes you exactly to where you need to be. Any questions?
At this moment, no current questions.
All right, let's get in there and clean this up. I got 10 minutes. Berndes? Oh, thank you.
Next patient here, ready to go?
All right, so we're going to pull back and we're going to zap away pieces of herniation as we do that. I always start deep in the disc herniation at the base. This is called the inside out technique because you're starting inside the herniation or disc versus the outside in technique, which is far more dangerous, where you start outside the disc and work your way in. More dangerous for the patient. I have always done the inside out because it's safer. for the patient. Honestly, I don't see a purpose of doing outside in. I've never really understood why. And by the way, well, I shouldn't say most surgeons, endoscopic spine surgeons, do inside out, because I don't think that's true. I think many of them do outside in because they're doing a laminectomy while they're doing their surgery. And I don't do a laminectomy. It's totally unnecessary with this technique. And it only hurts the patient if you do a laminectomy. Doesn't help the patient. That is a giant piece of herniation that's totally scarred. That's what we need to get rid of. Let's see if I can. It's not coming out. It's stuck down to the wall. So I'm just going to have to bust it up into little pieces and remove it. Again, we're never going to get all the herniation, so don't expect it. We do what's called a debulking. Debulking means we're getting the bulk of the herniation, or taking the girth of it, the mass of it down. Now look how all that gold color, that's calcium. And that's a reflection of the fact that this area has been under inflammation. You don't get calcification of scar tissue. That's scar tissue, by the way, scarred up herniation. You don't get that overnight. That takes years and years and years to make. And so the fact that we see it here means this herniation has been here for a long time. I would have loved to have gotten to this thing years ago when it was smaller and softer. But now it's hard, and that's why we were able to see it on the x-ray. If you rewind the video, you go back to the beginning. When we took that first x-ray, remember I said you could see the herniation? Part of it's because it's so big. The other part is because it's so dense. And dense means, simply put, that it's full of calcium. Very, very thick. That's all the stuff we're breaking up right now. Any questions?
At this moment, no current questions.
Well, let's play our video, Henry, on why do these herniations cause pain when they do.
Copy that. All right, great. So you can see now from our video how the herniated disc causes so much back pain in patients. It's all due to chronic inflammation. Chronic meaning going on for years. Inflammation is, you all know what inflammation is. If you ever had a pimple on your face or anywhere, that red swollen area is called inflammation. And It's the inflammation that causes the back pain. Redness, tenderness, and even can cause leg pain. Because, well, what happens is that inflammation spreads to the nerves going down the leg. Henry, let's show the audience how these laser surgeries done here at Deuk Spine fix the inflammation.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see how this procedure helps people by cleaning out the tear where the herniation's coming out of, but also getting that annular tear to heal, which the body cannot do on its own. You cannot heal an annular tear on your own. They just don't. They don't heal. And they're so easy to re-injure them. So people just keep hurting them, opening them up, reopening them, re-herniating, more pieces of herniation coming out. Like frequently we'll see, when we do a herniation like this, we'll see some really old parts from the original injury, and we'll see some younger parts that are more recent. That's the side wall of the herniation. The gold color is calcium. You saw it on the video how the older disc herniations have calcium and scar tissue that forms. This is all scar tissue from the herniation. It's like scar tissue around with the herniation inside of it. Any other questions?
Yes, sweet. This next question coming from Lanu, once more
2 minutes.
on YouTube, asking about sleeping posture. Can sleeping on the stomach cause a herniated disc?
Yeah, sleeping on your stomach will never cause a herniated disc. Okay, herniated disc is always due to a traumatic injury to the annulus fibrosus, the annulus, herniated disc. That's what causes it. So if you have an accident and you tear your annulus, that's how you get a herniated disc. You can't have a herniated disc without an annular tear. It's not possible. Every single herniated disc I've ever treated had a tear in the annulus as the source. 1 minute. Any other questions?
No current questions, but we do have a comment from Eric on YouTube
Sure.
saying, "Hey Doc, I am still waiting on Kim to call me back. Just wanted to let you know that I am here following your instructions and watching the videos."
All right, good. Well, Eric, I don't know. Do you have Kim's phone number? Let's give Kim's number.
Yep.
321
Copy.
775 1862. 1862.
Copy.
That's Kim's number. Give her a call. And
I don't know your last name. I don't want you to have to tell me. Otherwise, I'd ask her to reach out to you. But hopefully you can get in touch with her on her phone. Okay? We're ready to take care of you. Have we done an MRI review, Eric?
I think he mentioned there was a comment in the last live stream that I think he said that he did have an MRI.
He did have an MRI review.
I believe so, yes. I could be mistaken
All
now.
right.
Leave his information with Henry.
Yes, he just said yes.
All right.
Broadcast.
Yeah, we don't want you to have to broadcast. How is he going to leave it with Henry, though? That's the problem. Henry is looking at public, comments. Anyway, just call Kim's direct line, and if she's not responding to you, let me know next week, because she should. And I apologize for some reason if that's the case and she's not. All right, we are pretty much done. All right, I'm just looking around. I don't see any more herniation that I can get. I've gotten, well, at least 50%. Maybe I can get a tiny bit here, but there's a piece. Come on out. There we go. That was good. Oh, come on now. And the reason that's not coming out is it's too dense. I don't mean stupid. Huh? No, dense means it's got calcium in it and it doesn't float well.
We have another question.
Yeah.
This coming from Justin K on YouTube,
Oh, Justin K.
asking, what is all the fluffy white stuff?
Herniated disc, Justin, and scar tissue that is the result of the herniated disc being there. In other words, when you get a herniated disc, it causes inflammation. Your body attacks it, produces scar tissue, calcium deposits, all kinds of junk in there. And that stuff is what you're seeing. All right, we're done. I hope that works for her. It should. Again, muscles and nerves take time to heal, usually 6 to 12 months. So I expect her symptoms to get better, and she'll have to regain strength by walking and therapy, doing a kind of a therapy program. But now the nerves should be unpinched enough for her to do that. All right. Do we have it? I didn't do that yet. Alrighty then. We probably lost about 5 cc's of blood, maybe 10 max. These are relatively bloodless procedures. Certainly no need for hospitalization, as these surgeries are done outpatient. People go home the same day. Go ahead, do your thing. Scope you 6. All right. Well, Henry, if there's no other questions, you can wrap it up.
Copy that.